While the computers are being switched, I just want to thank Professor Alik Sagie for his invitation here and for his commitment to this as an important activity of the Israel Heart Society and the Cardiothoracic Surgical Group. I want to thank the presidents of the group, Professors Rosenman and Olatin, and I want to thank all of you for attending. There's a kind of sense of excitement in the air here. So many people attending this meeting and eager to learn about latest advances in valve disease. Professor Sagie put me a challenge to speak. I also wanted to thank the Sayeret in the back, Niv in particular, and Ben for saving the day in terms of the audiovisual here. They are really fantastic and the unsung heroes, so I'm singing their praises. Thank you very much. Kol hakavod. The challenge is to talk about mitral valve replacement versus repair, the view of the echocardiographer. There are basic principles that don't change and will not change with new technologies. And they're as follows, that the mechanism of leaflet dysfunction, as Alan Carpentier puts it, determines how MR can be repaired. So we need to understand that mechanism. Echo is ideal for identifying that mechanism. And therefore, there's a team that's developed between echo and surgeons in the operating room before and after. Our aim in all of these procedures is to restore the adequate surface of coaptation, as Professor Ronani was talking about, because that's what is necessary to prevent MR short-term and, importantly, long-term. I'll talk about these principles in mitral valve prolapse and also a little bit in ischemic mitral regurgitation. Mitral valve prolapse, Maurice Serrano has shown that the repair, if you take mitral valve replacement first, you get a decrease in survival compared to the general population. Whereas if you repair, you restore the survival to that in the general population. And we know that replacements have problems, potential problems, mechanical change, infections, thrombosis, and so forth. So a repair is better, and particularly when you've taken the stress off the valve with current techniques, the underlying disease seems to not act up, and you have durable repairs by and large. And that's improved over time. So how can we maximize the rate of successful repair? In principle, an experienced surgeon should be able to repair 90 to 95% of degenerative prolapsing valves. And even with current technologies, I think from the Society of Cardiovascular Surgery database, it's gone up recently, but it's still in the 50 to 60% range. So there are patients who could be repaired and have the benefit of repair who do not have that. So I think we need to understand these principles in order to maximize the rate of repair. There was an old movie called The Good, the Bad, and the Ugly. So we need to consider repair versus replacement based upon which are the most easily repaired and can be repaired by perhaps most surgeons, and the ones that are most difficult that require special centers of excellence and the most experienced surgeons. So the prolapse in the central segment of the posterior leaflet is easiest to repair. Fortunately, that's about 70% of the patients. A2, middle segment of the anterior, it gets harder in multi-segment and diffuse or Barlow's disease, and then COMMISSURAL and calcification provide particular challenges. So here we see posterior P2 prolapse. Thank my colleague Dr. Jacob Del Bianco for this. This is in a transthoracic echo. And we see in two-dimensional echo, this is a FLAIL leaflet with a ruptured cord here, large gap between the leaflets that defines the FLAIL. We see the eccentric jet of regurgitation into the dilated left atrium. And we can look at this in three-dimensional images. From the surgical view, we see this huge P2, what's brighter is coming towards you into the atrium. We see a ruptured cord over here. And we can actually look at that in real time. Just go back here. I think we can actually see this moving. So one picture is worth 1,000 words. We can see that the P1 region over here is pretty good. P3 is okay. Anterior is tucked well into the ventricle. How extensive is the lesion? Well, here we just have a two-dimensional view, but now with the modern miracles, you can just turn on the 3D and you can see that it goes from commissure to commissure. And we now have improved quantification of the vena contracta, the basic regurgitant orifice, done by Chaim Yosefi. Professor Yosefi is here with us today from Barzilai. And you can, using 3D, you can identify the narrowest neck of the jet here and measure it in short axis. And this is going to be over a square centimeter. That is quite severe. So you can measure, you can identify the lesion, and then repair it. This is fairly straightforward. A resection of the large offending P2 portion, put in a ring to buttress the leaflets, and you get a very nice repair. We'll talk about this subsequently in the discussion of SAM. Also, this lends itself to the edge-to-edge repair, either with the alveoli stitch or the percutaneous clip, which I will not discuss in detail today, but certainly lends itself to the buttressing procedure. And what about A2? A little more difficult, but also similar principles apply, different techniques. So the surgeon has a toolbox which they need to adapt. Here we see a large A2 flail, patient with recent onset of severe cardiac failure. She had had MVP for a number of years, pulmonary hypertension, quite severe. See the MR jet over here, very large proximal jet. See the ruptured cord. She didn't have endocarditis, but she was doing quite poorly. And neochordal implantation using Teflon cords or secondary chordal transfer from the posterior leaflet plus a ring are very useful and can repair the vast majority of such patients. So that's not too difficult. We get into difficulty when we have multi-segment prolapse, which becomes much more difficult. And here we see this is P2 and this is A2 going into A1. And you can see that this is a complicated valve. This is not just the sagging. Sometimes I call it the Gillenov effect. If you don't have enough support from the posterior leaflet, the anterior leaflet sags. This is really chordal disruption and leaflet disruption. You see this ugly gap between the leaflets developing in mid to late systole. So this requires more surgical detail, more surgical attention. This can be recognized also using the cross-sword sign, as Professor Be'eri has described it and published, where you get two crisscrossing jets. You count them, that tells you the number of leaflet pathologies that are going on. 2 jets, 2 pathologies, 2 leaflets. Now, so that requires, clearly repairing the posterior leaflet, but also doing something to tack down that offending portion of the anterior leaflet. That requires a surgeon who can do that until they achieve success. The same thing applies to advanced multi-segment MVP, referred to as Barlow's, where all the segments are basically billowing. This is from my colleague, Dr. Judy Hung, and we see this here in the real-time 3D. The entire valve is offending. There are different ways of dealing with that. Excising some portions, actually, of David Adams does one side of the valve and tacks the other down. I've seen Carpentier actually pull the chordae down and bury them in the papillary muscles. But you need a strong-hearted and willed surgeon to really get this to work properly. Then we have more difficult situations of commissural. Here we have an anterolateral commissural flail. You can see it coming in some of the frames here. So this is the center of the valve, this is the medial, and this is the lateral portion. There's this ugly portion coming out here. And it's very hard to fix this anterolateral flail with torn cord. You can put in a magic suture, as Carpentier calls it, and just, forget that part of the valve. But it's hard to fix, and in fact, this patient had an attempted repair that didn't go so well and may actually require a replacement, getting to our subject. So there a lot of regurgitation that didn't really respond too well to an initial repair, unfortunately. And then finally, calcification makes things harder. There are surgeons who will go in and ranjure out that calcification. often you see patients with not a lot of prolapse, but they have this dense annular calcification, or they may have portal calcification, MR out of proportion to the prolapse. So that might be an indication in some centers for replacement as opposed to repair. But then again, those surgeons of courage might be able to go in and repair that as well. So our summary is that echo guides the suitability for repair versus replacement, and also tells us which patients can be repaired in which centers, and which patients might need someone who's able to put together a long experience and get that success rate up to about 95%. Now, I mentioned about SAM earlier, systolic anterior motion, that can occur post-repair. We need to recognize elongation of the posterior leaflet and its effect on mitral leaflet coaptation in order to prevent this complication. Now, SAM and prolapse are cousins. They can transition from prolapse preoperatively to SAM postoperatively. These images are from my colleague in Japan, Yutaka Utsuji. So here's preoperatively. There's a little upper septal thickening, but that's par for the course. Notice the elongated posterior leaflet shifting the coaptation point of the leaflets towards the outflow tract. Again, there's no SAM here, prolapse. We see the MR. Then postoperatively, we have SAM, which is obstructive. So we put in an undersized ring, but there's residual leaflet elongation shifted now into the LV outflow tract. SAM results, as Ehud Schwamenthal and Barry Manner have shown, from the interposition of elongated leaflets, particularly with a high posterior leaflet, into the outflow tract. Now here we have this pertains whether you're an HCM or without septal hypertrophy. The same principle applies. It's an abnormal mitral valve. How do you deal with that? Well, here again we see with the SAM you still get MR, so you haven't gotten rid of the MR. This is because of the SAM, not because of a failed repair. And here we see the leaflets, floppy leaflets within the LV outflow tract beneath the aortic valve. So to get rid of that, you recognize the posterior leaflet is long, it's shifting the coaptation, so therefore you use the technique of shifting the posterior leaflet down, the sliding procedure, as Carpentier calls it, getting that leaflet out of the way of trouble. Also, you can use a large annulus. The annulus takes up the leaflet, it can flop around within the ventricle. There are various ways of doing that. Ask your surgeon. Just do it. Future directions for repair, we need to recognize that there might be a possibility, not in these patients, but in earlier patients, for early therapy based on understanding genetic defects. And Ronan Durst, who's with us here today from Hadassah, has been working on that with the Leduc Network. You'll be seeing his paper soon on a gene defect that causes disorganization of the cells in the valve, which also triggers modifiable pathways that lead from gene to degeneration, from disorganization to myxomatous disease and clinical disease. These pathways include TGF-beta, which is activated in some recent surgical papers and can potentially be treated if you get there early enough. So these are things on the horizon. They don't apply, obviously, to the patients in the operating room. What about ischemic MR? Well, the most dramatic example, of course, is papillary muscle rupture, this movie from Professor Sagie at Rabin Medical Center, where you saw here's the ruptured papillary muscle head with a severe regurgitation. This can be treated with the similar approaches as degenerative mitral regurgitation, mechanical approaches. But we have a bigger challenge in run-of-the-mill ischemic, or rather post-infarction regurgitation, which is really a ventricular disease, as most surgeons will recognize, caused by the bulging of an infarcted wall, displacing the papillary muscles, tethering the leaflets away from the annulus, causing failure of coaptation. And as Mark Ilanov has shown, even in this situation, repair has a better survival than replacement. So for the same reasons, there's no reason that replacement should do any better in this situation than in the degenerative situation. So how do we achieve repair? And this tethering, I should just mention, there are many people in this room: Ehud Schwamenthal, Noah Liel Cohen, who's actually on sabbatical now, Dan Gilon, Ronen Be'eri, Alik Sagie, Moti Baturi, Chaim Yosefi, and Yutakon Mark Hanschumacher, who contributed. This is like 10 years of work showing the role of tethering. Now, the rationale, as Professor Be'eri has discussed, for repairing ischemic MR is that it independently drives LV remodeling in the infarct remote myocardium. So you really want to preserve that myocardium, and that's one of the major reasons for repairing that. There are competing forces determining the position of the valve. There's tethering, which is increased with the infarction, and then there's closure. Because there's this dynamic, therefore, there's a dynamic orifice, greatest in early and late systole, and least in mid-systole, as Ehud Schwamenthal showed in a landmark paper. Of course, as it becomes more severe, it's more holosystolic. Because it's dynamic, it can also reoccur as the ventricle dilates. So as the LV continues to remodel over time post-operatively, the frequency of recurrent MR, that is, it went away after you put in a ring and it did a CABG, it comes back. And here it is in going from around 20% all the way up to about 60% recurrent MR over time, from 3 to 6 to 12 to 5 years post-repair. This is not what surgeons would like to see. They're frustrated by this because putting a ring in is only dealing with one end of the tethering balance. Here's an undersized ring. The leaflets are still tethered. The ventricle is getting bigger, as we showed with Carlos Duran, and therefore there is recurrence of the mitral regurgitation with all of its consequences for morbidity. So if it's not ideal, the repair, should we replace? So very often at surgical meetings, someone gets up there, a surgeon, and says, okay, it's all right to replace. I bless you. So there was a recent multi-center study that was done, randomized trial, 250 patients, supported by the Heart, Lung, and Blood Institute, the CTSN study, which showed, interestingly, in those who were repaired, so they had CABG and repair, ring repair, undersized, for ischemic MR, 32.6% had moderate to severe recurrent MR. That's a third, not a good result. My colleague Judy Hung was the director of the Echo Lab for that. This is published in the New England Journal here. And these are the results. This is death. Notice, interestingly enough, that in the mid-portion, before a year, mitral valve replacement seems to have a higher mortality rate than repair, but they kind of even out at the end. Similarly, all cardiovascular endpoints, this midpoint where this is greater. But nevertheless, statistically, there's no difference. So they concluded that we observed no difference in LV remodeling or survival at 12 months between repair and replacement. Now let's think about that for a minute. You can say, okay, well then in that case, severe ischemic MR should have replacement. Why bother with repair with recurrent MR? But as Mark Gilinov showed, and there's no reason to expect that a replacement does not convey an adverse prognosis, okay? So that means that a repair is also conveying an adverse prognosis. It's not that they're equally good. It may be that they're equally bad, okay? And this suggests that we need to consider approaches, ideally surgical approaches, to repair in an improved way. We're not using an ideal repair. We're using a repair that fails in a third of patients. So we need to reduce tethering, either at the chordal level or the papillary muscle level, or, as Ronen Be'eri was talking about, promote adaptive leaflet growth to match the remodeling ventricle. I can't go into that in more detail. Time is up. But basically, ECHO guides the suitability and approach for repair of all types of mitral regurgitation based on an understanding of the mechanisms involved. In ischemic MR, we need to understand the tethering mechanisms in order to design future repair approaches that should be tested. We should not stop at the CTSN. This should be the beginning, not the end. Thank you for your attention.